fortunate because I didn't think I needed any introductions, but I wasn't sure I was going to get one. But now that our leader, perfect spiritual master, is here, good job.
So, hello everyone, and thanks for coming. We're really privileged today to welcome Professor Mark Frisse from Vanderbilt University, who is our invited speaker. Professor Frisse started his career in Washington University. His area of expertise is medical informatics, and he used to be an oncologist. And he subsequently to his Washington University experience, he went to the industry, First Consulting Group, and after that he went to Vanderbilt University, was Accenture Professor of Biomedical Informatics, and he's also a professor in Vanderbilt's own School of Management. And the primary area of his work in the last few years has been health information exchange, which is a topic of paramount importance for our evolving healthcare system in the United States, and involves all stakeholders in patient care, but as we will see, it has a very, very strong component of medical information science and technology. And we're very, very happy that he's here with us today to share his expertise and also his experiences. Thank you.
The way this actually happened, like all things in New York, was my wife and I last fall, I have a daughter, the second one at Barnard, and we ran into Constantine and his wife, of course, in Columbus Circle somewhere walking down the street. So hi, hi, as it always happens. I've met friends from all over the country in New York City on the streets, and it's a bit of a second home to me through my daughters. I'm a fellow of the New York Academy of Medicine. There's a very long story to that. A lot of friends. And so when I ran into Constantine and we started talking about his work, I said, gee, it's just great to catch up. He said, come visit sometime. It's so far it's been a great honor. The neat thing about this field is that anyone can pick a topic and focus on it, and with discipline make an enormous contribution. Constantine is very rigorous, and his group, as some of you know, works hard in a very focused way, in a very collaborative way, which I think is essential to what the biomedical research enterprise is really all about. As he said, I'm a product of Washington University School of Medicine, where I actually made it to the rank of full professor with tenure without doing bench research, which still mystifies me how quite that happened. I was involved with some genome research, a lot of infrastructure. I was actually the library director for a while, taught at the business school, taught at the graduate computer science school, and quit. Got tired. I realized that I was teaching at the graduate business school and didn't have any idea what a real business was like. And so I met a fellow who had a large pharmacy benefits management company, and he said, would you like to help build a website for 60 million patients? I go, that sounds pretty big, that sounds good. And so I actually quit. They wouldn't give me a year off, so I quit and walked from it. And I was humbled by how challenging it really is to work in a sense where your degrees and your pedigrees don't count. The only thing that counts is how effective and focused you are. And I learned something from that, and that is advice a elderly lady gave me in a plane. She said, the secret of life is to find out what you're not good at and don't do that. And I've tried to follow that ever since. So now I don't manage anymore. I'm not in the private sector. Rather, I teach people how to manage because I can't do so well. Ask my wife about that. Along the way, also, I did work, as Constantine said, with a consulting firm, because I wanted to go all the country and see how this healthcare technology stuff is really working. And so my expertise is really, I've worked a lot with Farzad Mustashari, formerly from here, who runs stuff in charge of the high tech, the Office of Network Coordinator. I have friends over many years in many disciplines. The thing I know the least about, and I will not talk about it all, of course, is really the fundamental core of the translational sciences stuff. The neat thing about, I guess, my feeling for your group here is I respect it so much and understand it so little. But I have a sense about the rigor and the theory and the collaboration. So what I'm going to do, I'm going to talk about my world and what I know. and what I know about New York City and the metropolitan area, and make a claim down the road about what scientific research, clinical research is really going to be as we look into the next decade with the using of information technology. Now, I understand I'm fairly humble because of the size of the clinical trials that have come out of this institution and the kind of labors, but I'm going to at least tell you what I know, having been in the bowels of this city as well with the politics and up in Albany and everything else with this area of healthcare information technology. So it's going to be kind of a clinical talk, kind of a national healthcare talk. It's not going to be a real quantitative scientific talk. That's just a consumer advice, and I will not be hurt if you head out the back door for dinner. I'm going to talk about demography for a minute and the population. One of the biggest challenges, I think, if you step out of the grave concerns we have about funding NIH, funding NCI, funding NSF, funding our research enterprise, is an overall thing about why does healthcare cost so much? I mean, I bet all of you come home, and no matter what your position in this institution are, you're kind of peppered with things you know very little about. And I'm going to make the claim that our concern about healthcare for this hospital, this medical center, is not driven so much by whichever party happens to be dominant, but rather by some fundamental attributes about the American people, about the American economy, and where we're heading. I'm going to talk about the constraints on that. I'm going to talk about strategies, and I'm going to talk a bit about accountable care organizations and all of these other groups that you hear about and read about, and my concerns about that. And then I'm going to bring it back to secondary and long-term use. Because at the end of the day, we've got to figure this out so we can take care of our patients in here and now. 2 weeks ago, an associate director of the NLM asked me to give a talk on long-term preservation of electronic health records and how we would archive these things for future research. And I kept saying to myself, I would love to be able to gather this data and do research this afternoon, and I can't. So if you look at our society where we so seldom invest in even the short term, in next year, in education, in scientific research, in, well, let's mention a tunnel, maybe over to New Jersey, when we so seldom do those kind of things, how can we possibly think that we're going to be able to invest in the long-term data infrastructure for the research enterprise? And I'm claiming that one part of this puzzle is to figure out how to unify the clinical mission, the people who are in the back room trying to figure out how to make sure Empire Blue Cross Blue Shield pays you what you're supposed to get paid, and at the same time find a way to use these data in a way with consent and IRB approval and like for research today and tomorrow. And New York, you know, this state is large, but it's made an unparalleled investment in the infrastructure in trying to unite competing organizations together. I know NYCLIC's pretty well, a group on the Upper West Side. I know the Montefiore people quite well. As you know, over the last basically about 6 or 7 years, the bond authority in New York has been putting tens and hundreds of millions of dollars into trying to get disparate healthcare organizations to make patient data available, with very mixed success, I may add. But that said, why is that important again? Well, it's very simple. If only our patients went to our institution only, it would be pretty easy to get a good view of what's going on, but they don't. The average Medicare person goes to 5 to 7 different practitioners, and with the exception of the health department, safety net clinics, and some of our large hospitals, healthcare in New York City is particularly fragmented, it seems to me, and particularly kind of balkanized, although that's kind of the case everywhere. Here's the kind of numbers that we're talking about, and when you really look, over the last 7 or 8 years, it's about $532 million. Now, a lot of that payment in kind is funny money, but $250 million from the state of New York to invest in building an infrastructure is still a lot of change. Even in a high-tech area, that's a lot of money. A lot of that's being run now by a woman named Rachel Block up in Albany. And so, again, this may be alien stuff to you, but you may hear the words health information exchange a lot, or RIOs a lot. And again, I think more like an economist, I guess, than a scientist. I guess my economists would like that distinction. But I think of exchange as just when I send a message from one person to another. If I'm sending a data set, or if you're collaborating with me and you're seeing the outpatient, or we're doing a collaborative clinical trial, that we, under certain contractual agreements, basically make data available. I call a health information organization the legal entity that does that, be that again, international collaboratory for a clinical trial, be that a collaboration of hospitals and clinics in your neighborhood, neighborhood, be that a state level organization. And my fundamental claim is that when we're taking care of patients, increasingly we're going to see a lot more of that taking place. We're going to see a lot more of the data, at least theoretically, within our grasp as researchers to advance this. But it's no mean feat to get there because of distrust and a few cultural aspects I'm going to talk to. So the other thing is I don't ever really talk too much about the stimulus funds and the high tech and all the money for EHRs. I know when I look at the cost of your Epic implementation, you're counting on a lot of that to come through. And I think the initial stuff's kind of a very good idea, but after that I'm a little concerned about it, frankly. But I'm going to talk about why, even without government subsidies, why it is critical that we do two things. One is that we keep finding Gleevec, we keep finding blockbuster drugs, we keep recapitulating the story that we had in this city and across the country in HIV from the mid-1980s to the current time, or basically there is no way out. And the second thing is that we have to find ways when we're taking care of people to take care of them across the transitions in care, across their care settings, because we can ill afford inefficiencies. But you see, the strongest case I can make from the bureaucratic federal policy level about coordinating care and saving money from avoiding tests and things like that is nothing. It's a drop in the bucket compared to the breakthroughs we need. If we could find more breakthroughs in chronic disease, if we could accelerate the pipeline for research, and if, of course, we could take care of end-of-life care more humanely, I think we have a way out of this. Age. We've been getting older, and I'm sure that's common to you. When I trained in the late 70s, early 80s, no one over the age of 65 got a coronary artery bypass graft about anything else. It was inconceivable anybody that old would be considered for those kind of treatments because it was life-threatening. Hip replacements were very nasty, high mortality care. Now, of course, it's routine, right? So when you think about that, the average age has increased over the last 4 decades, 6.6 years on average, women more than men. And you multiply that times the population, you see some staggering numbers. What you really see is when I did a big study for long-term care in New York State, we call progressive intermittent frailty. You see that in the hallways here. You don't have people who are in their 50s and late 50s and get retire, slow down, go to the nursing home and die. You know, it's not like a one-way conveyor belt with an early mortality. Rather, people get intermittently frail. They come in, they go to rehab, they go back out, they come back in, they see their doctor, they go with their lives, they go back to their homes, and they go to retirement communities. So we go back and forth, back and forth, and back and forth. But again, you can see that percentage, Eddie, as well as I can, that particularly by 2020, the number of people 85 and above will be doubling. The number of people between 2000 and 220 that's above 65 is going to be increasing by about 50%. Those numbers are staggering. When you look over the 40-year projection by the the Government Accountability Office, it's quite staggering. These numbers are pretty solid numbers. Then if you look on top of that, the fact that we're obese. I mean, Manhattan's actually not obese, right? I think the figure actually shows that, you know, I guess maybe it's Darwin in action here, but you don't see the same kind of people, I can assure you, walking the streets of Manhattan that you see the Six Flags in Tennessee. You know, but in general, as you know, I certainly can tell you for me, obesity is a real problem. I have incentives to lose weight. I choose instead to go to a tailor and have suits that fit me that make me look less fat than I really am. If I could only find something too tall, I'd be fine. Bottom line is, if you look, and you look at the bottom here as well, at the cost of health care, it's really, really staggering. I guess that's the next slide. And that is that if you look back again, back in '87, the difference between treating a heavyweight person and an average weight person was very small because we had not gotten good at it yet. So you just didn't try to do stuff. Now, not just like my 84-year-old mother, well, she's, about 4 years ago got a hip replaced and dances with my father. You know, we tackle the morbidly obese without much difficulty now because of the triumphs we had. So guess what? We won. We have done remarkable things in clinical medicine and research that allow people to live longer and better. And as a result of that, the costs have gone up a great deal. That leads again to demand for primary care. And again, that's a particularly challenge to me, trying to figure out what primary care should be like at an urban medical center. And I'm just not sure. But if you look at the numbers, the demand is estimated to increase 82% again. Why? Because people are getting more insurance. And in our current healthcare system, where primary practitioners are expected to do primary care, right, we have a huge number. But why don't we have them? Well, let me show you number first, why we have specialists. these numbers, and you probably can't see them. Bottom line is, again, over the years, our appetite for very expensive procedures has gone up and up and up. In my high school class, only a couple people went into orthopedic surgery. We used to make joke that they had filled their applications out in crayon. Now you've got to be AOA and everything else, and everybody wanted to be an internist and a surgeon when I was there. Now everybody, of course, is going for those kind of specialties. And you can see the demand and what that's done. Interventional cardiology, miraculous thing, weights, going up and up and up, knees rather. But why? Well, it's real simple. There's a principle in accounting just called net present value. All you do is you figure out how much money you make every year, and you discount it by a certain inflation rate and roll it all back. And some people have done studies about if you go into primary care versus if you go into specialty care, and then you figure out if you go into specialty care, you spend a few more years where you have a lower income, but then you offset it with higher salaries. And they've ran those numbers, and they've ran them over different salary things all the way back from the 80s when I got out to the current day. And you'll see, well, 5 years ago, and you'll see that back when I graduated from medical school, and some of you that here, there was very little difference in income, actually, relatively. It seemed like a lot of money then, because it was. Now the difference is massive in between primary care and specialists. And if you roll that back, surprise, surprise, the average hourly salary netted out, the difference is $78 versus $30, okay? 2.5 times higher if you're in specialty care. Oh, and did I tell you the lifestyle's a lot better too, and people don't call you in the middle of the night and all of that. So other than that, it's, just great. So obviously that's a problem that needs to be solved, and that's not the problem we're going to solve today. There's also a bunch of work, if you want to do it, about the impact in age, how much of the costs are due to age, how much of these are due to technology advances. Those are all economic guess, if you will. But again, what we see is a dramatic change in terms of the aging workforce, like I said, or aging retirees, right? 6.6%, 6.6 years longer, times 50, 100 million people over their lifetime. That, even at a steady state demand, is going to require a lot more internists, a lot more surgeries and all. Then you add obesity, that drives up your cost. And then besides that, the technology gets better and better and better, My wife is a beneficiary of a lot of these drugs. Those of you who treat rheumatoid arthritis, we were talking about Remicade earlier today. Magical drugs that did not exist. And as a result of that, the combination of those two disruptive forces that keep us so healthy are driving the costs up to an insurmountable amount. Now, is that a bad thing? No. When I trained, one of the most common procedure, two of the three most common procedures, I believe, were exploratory laparotomy and vagotomy and pyloroplasty. And anybody who's trained in the last 15 years doesn't even know what those things are, right? Exploratory laparotomy, because before the CT scans were very good, much less MRI scans, the only way to see what was going on, other than lymphangiograms or pneumoencephalograms, you opened them up and you saw what was inside. It was really that simple. Exploratory lap, you did them all the time. Length of stay post-op recovery, 7, 8, 10 days. Post-op recovery for cholecystectomy, 5, 7 days. Now, almost an outpatient procedure, right, with laparoscopy. Okay. The other procedure was vagotomy and pyloroplasty. That was for ulcers because, God, I feel like I'm back in Peter Van Brigham in the 80 years ago when they're feeding people raw liver for pernicious anemia. I feel like I'm talking about the dark ages. But when you had ulcer disease, you would just take antacids, alternating back and forth, back and forth, back and forth, back and forth all the time. And then the only other thing you could do is literally denervate the stomach, hoping you would die, because H2 blockers, the purple pill, all these things have transformed America. So what happened was we eliminated peptic ulcer disease, then we found out it was an infectious cause. But at the same time, of course, it's an expensive medication, and everybody had a little heartburn, so everybody got the purple pill. It's like my kids, when they were 3, they knew what, Dad, I don't feel good, I want a Z-Pack. They have these things, and we drive up the demand. So it's getting crazy. Now, the other problem is that if you look, the histogram at the bottom is what percentage of out-of-pocket costs does the average American see? So if I got a dollar bill, or I got a $100 hospital bill, what percentage of that do I actually pay? In 1965, it was 50% because we had commercial insurance. Now it's 15 cents on the dollar, okay? Now, there are enormous disparities. As you know, people who are uninsured pay it all. In fact, they sometimes pay inflated prices over health plans. But meanwhile, the cost has gone up and up and up. So when you really talk to your family, your parents, relatives about the healthcare costs, they're not talking about the total cost because they don't even have a clue what they are. They're just talking about their out-of-pocket expenses, which are only 15 cents on the dollar. Think about it. Think if we all went to the restaurant tonight and we all knew we only had to pay 15%, would you order a better steak, better wine? Darn right you would. Simple human behavior. When we have no consequences, or as economists would say, the elasticity is of a certain value, we want to drive up demand. I mean, it's just human nature, of course. It's good stuff, 15% on the dollar. Let's do it. So, I talk to my parents, and I point out they're well off, but no, they say, I've earned my Medicare. And there's some Newtonian classical moment between 64.99999, and I know some of you quants can figure this out, and then 65, where all of a sudden you've earned all this stuff. How'd that happen? And have you earned it? Well, here's the real numbers, folks. And this is from the definitive source, which is the New York Times. It's actually, I look back at the primary source, I already do, but I always point to the Times articles. Basically, if you have a two-wage earning family, there's no such thing as a single-wage earner anymore, really, and a low and a modest income, you have about a $325,000 gap between what you were expected to consume through your Medicare at a 2%, if I remember right, inflation rate, versus what you pay. So every American that gets that Medicare with that kind of income, they're going to spend that much more than they earn. I mean, 100,000, as you know, one course of tumor medication can do that. Now, if I have a higher income, I pay more Medicare taxes, but I still have a $244,000 gap. Why? Because Medicare is taxed. You only pay taxes on a certain amount of Medicare. And that's one of the things people are arguing about now. You know, means testing Medicare even more. It's not going over well. So the bottom line, of course, is that the federal deficit is really in bad shape. And if there's anything I know, it's that when everything's going bad, people put away the long term. Ironically, the time we need biomedical research and critical thinking even more is a time we discard those values because we're just grasping to get our purple pill or our knee replaced or something else, or not pay more for my prescription drugs. Which I'm not saying do not disable the ability of elderly to pay. I'm not saying that the high price of prescription drugs doesn't stop prevention. Believe me, I understand all that. But at the end of the day, the problem is so much, much worse than we think, okay? Now, you say, well, let's have people pay more. Well, there's a problem there too. You can't make this up, but we're basically broke. That's what this slide says. I mean, when I really look at the overall debt, it's about a 378% increase in consumer debt. And you know these figures pretty well too. Most people will not be able to pay for their own housing when they retire, much less repay for all those hundreds of thousands of dollars of Medicare costs. So it seems to me, and I use these a lot being a certain political persuasion living in Tennessee, that it's not about what you think about the health care reform bill. It's not about what you think about this plan versus that plan. The bottom line here is there's some fundamental things that need to be fixed that so far go beyond that. And so that's why I think we have to count on our reputation as miracle workers and as methodical, thoughtful, critical people practicing everyday's best medicine if we're going to have a hope. So let me tell you what else is going on, because I certainly didn't know about this till I got a real job. And that's the kind of conflict that goes on with the hospital administration and the medical school administration is doing all the time in terms of healthcare prices and stuff. There's this guy named Joe, Microsoft cut out, right? Think Joe. He wants stuff. He's got healthcare. He's paying 15 cents on the dollar. What a reasonable guy. He's going to pay 15 cents on every dollar of healthcare. Then he's got an employer. And his employer says, well, I'm really paying your healthcare. Now, the employer's really not paying healthcare. Their employer is one, Joe, whether he knows it or not, is getting government-sponsored healthcare because in 1947 they made the healthcare insurance, as you know, tax deductible. So he's getting government-sponsored healthcare no matter who he is. And on top of that, as we know from many different labor negotiations, employers only have a certain amount of money to spend. And when that money's gone, they have to stop. So a lot of the labor strikes, you know, are over healthcare benefits versus wages because there's only so much money. So in a way, either Joe's paying that out of his salary or I'm paying it out of how much I pay for whatever Joe makes for me, okay? Then we're on the other side. We're the good guys here, right? And we know that the demand is going up, the costs are going up, they're getting older, sicker. We're looking at all that, and we're just sincerely saying, look, miracles cost money. This is not easy. You say you don't need it until you need it, and then boy, do you need it, right? And you want the right thing done, and we pride ourselves that we do that. So, how do you do that? Joe wants everything for himself and his family, doesn't really care what you get, or I get, right? But cares about that. And we say we've got these massive problems, and in between, of course, sits a health plan. And I was in a business where I actually sold the health plans. I know health plans very well. In a way, I'm not a big fan of health plans because they're like banks that keep our money, decide how it's going to be spent. And the best business model I know is get the money first and hold on to it as much as possible. And whereas we have to wait for what comes down. But secondarily, of course, they have a fiduciary responsibility to try to give Joe as much as he wants, which means be you the government, be you a private health plan like Empire, you've got to find a way to basically squeeze everybody as much as you can and get this stuff done. Because the problem is there's not just one Joe, there's a zillion Joes. So there's a fundamental disconnect between what we all want and what we're willing to pay. Now, why is that important? Well, it's important because as the federal policymakers have been talking about accountable care organizations and how we'll all get together and assemble risk pools together and we'll manage it like an HMO, manage these patients. Well, if you ask me, the accountable care organizations, the default is going to be the health plans because they get the money first and they already have all the technology to do a lot of this stuff. If they need more money, they can keep more of the money that they would give us and continue to invest in that. Furthermore, and the point I would make in New York and everywhere else, is to the extent that providers do not collaborate when they take care of the same patient with the data, because they say, well, I'm not going to send this stuff to Cornell Wild because they'll steal my patient. To the extent they do that, they're actually weakening their leverage with the health plans. Because think about it, 5 of us are going to be taking care of the same patient, but we all don't know what each other are doing, and we go to negotiate for our plan, our position's weaker. Because we can't tell you the whole patient picture, only the plan can. Probably not real relevant to you, but nonetheless, I think it's important to understand that while we're sitting here thinking these big thoughts, there's a titanic struggle going on between healthcare providers and healthcare plans with limited resources that's consuming a lot of energy. In fact, a lot of the information technology investments are really done basically to fight that battle. That's why ICD-10, we're moving to. It's a wonderful way, I guess, to describe diseases if you do it right, but the interesting thing is they say it's used all over the world. Yeah, but nobody else sends bills with it. We're planning on doing that. And these things cost millions and millions and millions of dollars to do. So what we have to do, particularly if you're a data warehouse person, for example, is we've got to figure out, one, how to use those data to advance our research mission, and two, we've got to figure out how to collaborate with our competitors to cover an entire life so we don't just look at a specific instance of a life. It's great if you're doing acute care, but we look in the longitudinalness of that and we try to measure it. So we need to get all the information we have in the same place. So then to understand, let's look at what we really want to do with the Epic installation here. It's important to understand that a hospital is really 3 different things. It's a problem-solving shop. People come in, I hurt, and your job there is like a diagnostician or a consultant to solve that problem, right? You use an information system then to look at the biomedical literature, look at the clinical data, and to basically solve the problem. So it's an information theory entropy reduction problem. Then you come up with a care plan. Then the next reason we use our electronic medical record is because once we have a care plan, then we kind of go on to production line, like a Nissan automotive line. Acute coronary syndrome, you do this, you do this, you do this, you do this. So we talk about quality, Six Sigma, closed loop medication management. We're just basically using our electronic health record and our collaborative work systems as the equivalent of a automotive manufacturing monitoring system. And that's where most of the emphasis, of course, is going with the Epic system right now, is to help make sure that teams of people can coordinate care very quickly. Because as you know, like Southwest Airlines has 60 fewer planes than a lot of other airlines of the same size. Why? Because they get them in and out faster. You know how expensive a hospital bed is in this institution. Well, if you can increase the throughput and get somebody out a few hours earlier and replace that bed, you can create more virtual beds, just like Southwest Airlines seems to have more planes than it does because it turns them around so fast. That's why you always walk way out to the end in the Southwest Airline gate, because they get in and out of the airport faster. That's why you have open seating, is because they can turn that plane around. You measure the waiting time when, like I do, go to LaGuardia, American, and compare that to Southwest. So a lot of what we're trying to do in the hospital with electronic medical record is simply that. The final reason we use electronic medical record, though, is basically as an external communication entity with our referring physicians, with our clinical laboratories, with our health information exchanges. We use that kind of like a stock exchange there, where we know if we have a critical mass of providers that we can cover 90% of a certain patient population, we can do a lot better research than if we have fragmented stuff. Now, in the business world, that second thing is sometimes called a value chain. It's the diagram they all look at, and all the MBAs say, yeah, I know that. I don't know if they've ever read the book or not. But it's a simple idea again. It's a production line, okay? I get somebody coming in, they have a certain problem, I know what it is, I run it through and I make sure that I do the surgery, I get the post-op, I do the discharge planning, the medication reconciliation, and I just keep going, and then I do the follow-up and I'm done. It's like a factory. Boom, Nissan Automotive, okay? But here's the problem, of course, and that is in America, healthcare is incredibly fragmented, right? So what's really happening with our typical patient is they kind of go and say, well, I'm going to get a car, so I'm going to go to Nissan, and I'm going to get that Nissan frame, and I'm going to get Goodyear tires. Then I think I'm going to get a Chevrolet interior, and then I really, really like that Ford truck thing. So I'm going to get a Ford truck, and then I'm going to get a Volvo engine because I heard they're really good. Then I'm going to get in my car, and I'm going to turn it on. It won't go anywhere because I didn't have a transmission. Nobody told me I needed the transmission. Whoa. So what we really have in this city is we don't have the mentality we have in a hospital of an efficient production process. We have all kinds of people who are trying to optimize on their own and not talking to each other. So you understand why healthcare gets kind of expensive and crazy. And furthermore, of course, our system rewards us. The more we repeat stuff, the better off we are right now, right? Those days are going to change, but that is. So the only way to make this thing work, and the reason why what I think this whole New York State investment ought to be about, is to help use data structures to coordinate care. To use a way that anybody can get onto their system no matter what it is and see where they fit in the process. Oh, you need the tires now, or you need the interior now, or this or that, and communicate. The right model, in my view, for electronic health record is not an electronic chart. It could be nothing further than that. It is a telephone. It's a communication device among people to coordinate care. It's a device that, as an after effect, creates an audit log of what transpired so that we can do research and stuff. But it's more than anything a way to coordinate care. And so what we need to do, not just within our own institution by getting like your Epicness all right, but across institutions, is find ways to coordinate care. So when that patient appears across town somewhere, you know where to pick them up and what you can do. Now, we actually did that. The reason I came back to Vanderbilt was not to join the faculty at Vanderbilt, although I'm loving it. The reason I came back was because the governor of Tennessee, who was a very, very prosperous guy, who was just a solid middle-of-the-road businessman, wanted to create a health information exchange in Memphis, Tennessee. And the political climate there will rival what you've got here, and I know the political climate among your hospitals intimately, but it was the same thing. It was civil war. But it's amazing when the governor comes in and sits you down at the height of a Medicaid crisis, when you've got a big, huge regional hospital that's about ready to go under and deluge all the rest of the emergency departments with uncompensated care, how much power that is. So just imagine if Governor Cuomo came down and met with all the hospital heads and said, hi, you know that budget cuts, all that horrible stuff they want to do? Well, I'd like to be on your side, but to be on your side, I'd like you to volunteer to collaborate. That's what the governor of Tennessee did. It wasn't collaboration, it was coercion. He called it the Volunteer E-Health Initiative, because Tennessee's a volunteer state. It should have been the Voluntold E-Health Initiative. And all these clinicians got together and they decided to collaborate because they planned, and we got an ARC grant, and we did this for, I don't know, $9 million. We didn't know it was supposed to be expensive. We just did it kind of cheap. And we basically got all these people to agree that all their medical information would go into one place and be available in any other emergency department in the city. And it was all the medical information of any hospitalization, any visit. We took whatever went. So now we have this exchange that I helped build, and now I'm completely out of it. Now it's all running on its own. When I took the job at Nashville, I knew about as much of Tennessee geography as you did. I had no idea that Memphis was 220 miles away. I realized that would be a problem. So I was managing a project far away, where at least everybody hated Vanderbilt equally. That was one nice thing. But so we navigated the politics, and we built this huge system that actually works pretty well and pretty cheaply. We have 1.2 million patients, people in the city, and the operating costs are about 1.2. That's $1 per person per year. Healthcare costs, I don't know what they are in New York City, but in most metropolitan areas are about $8,000 per person per year. $1 to coordinate care, to make the information available, $8,000. I mean, that's less than we spend on advertising. So again, my central claim that I give to administrative people is, while you're busy fighting with each other at hospitals, for that $1, you could find out what's going on with your patient. Then you could go together, and when the Blues plan tells you you're doing bad quality, say, oh no, we're not, look, here's what we're doing. And if you do it right, then you see, then all of a sudden you have access to data sets, if you will, that are far beyond. Talk about our strategic resource for CTSA, something like that. It is that longitudinal data set as an open shared collaborative. A lot of stuff to do, you just can't pick it up and do it. So again, I told you kind of what we did. Real-time data, you know, they said, well, what standards did you use? None. We just said, what do you got? Because what we needed was, we needed a model of technology to see where you'd have a bunch of entities that didn't like each other, didn't want to work together, really, really didn't even care about common technology platforms, and were always fighting. So that's an academic medical center, right? So that's no problem, because we had exactly that kind of model at Vanderbilt. And what we did is we have all these systems that would feed into this data repository, each from a different kind of data type. We keep the original stuff, we wrap it with something, put a tag on it, and say, you're a CBC, or you're a white collar. We kind of know where it came from, we kept the context to it. So we could take all that stuff and then we could spit it out and make it look like it was all from one place. But it wasn't. So the average cost for a hospital to participate in this thing was $50,000. And that includes executive time for the meetings. The most expensive part was quality assurance and getting the privacy agreements right. Okay, and it's ugly. I mean, for those of you who have seen Vanderbilt, this is a real stripped down version of something called Star Panel that they use there. And it's, that's not pretty. And it's sat in the emergency department with a two-factor authentication browser, an ED whiteboard, so you can see which patients came in, you can click on it, and you could look at it if you wanted to. No incentives, no nothing. Here it is. If it helps you, it helps you. And if it doesn't, don't use it. And it turns out, again, like I said, for about 8% of the ED visits over the course of all the years it's been operational, people have been looking at it for things. They've just been saying, it's worth it. Because when you're an ED and you can quickly get an information from that patient you're not sure, the classic is like the person who comes in, you haven't seen them before, they're overweight, they've got guaiac-positive stools, they've got a crit of about 32, you go, better work them up. Then you see a graph of their CBCs and realize they've had guaiac-positive stools and had to work up 5 times across the community. You say, well, I don't think they're going to bleed out on me here. I can be different about that. We can show that we've saved lives. A ruptured ectopic pregnancy that, frankly, we don't publish this because somebody missed it 2 weeks earlier in another hospital. A guy that came in PPD positive, or active tuberculosis actually, with a wound and hadn't been treated. He left AO against medical advice. And he came in with just a wound, and they saw he was PPD tuberculosis, active tuberculosis, coughing away, so they isolated him. We found all kinds of things like that, and I'll tell you in a minute about money. But the bottom line is, when you start doing this, you go from the notion of retrospective data analysis with claims to real-time medicine. It's Google world. It is just what's happened this week. What's the cholesterol of New York City this week versus last week? How much does Tennessee weigh? You can start thinking like that. You really can. And there's ways of doing it. So we found other kinds of other things to do. You can't make much out of this. This is just a histogram where we said, what happens when somebody leaves our place? What happens when they left the place called the Regional Medical Center, the public hospital? Where did they go next? And for all the clinics we had wired up, we found out they went to CCHS and Health Loop. Those are 2 safety net clinics nearby. But the most frequent place people came was back to the Regional Medical Center. Because it turns out they did a bunch of surveys. The best place the public thought to get primary care medicine was the emergency department at the Regional Medical Center. Hours were good, the care was good. In fact, when we studied that medical center in the urban area, and we exchanged all this data, the number of people that used Exchange, the number of chest x-rays went up dramatically. They don't cost much, but they went up dramatically. And as best as we can tell from interviews, it's because they were practicing primary care. They were following up illness. Once they're in there, these docs are not going to let you go. And so they followed well. The other thing, real-time medicine, we were able to say when Asian flu, and I again apologize for the site and so on, you might be able to see a little weak dotted line going up there, back at about 427. See the green lines and the blue lines? The weak dotted line was the Google web hits on Asian flu. And Google was very proud of the fact that they completely outlined what the public health reporting said it was real time. Well, we did the same thing at the same time. We just said any record with the word influenza as an admitting complaint and a diagnosis, anything, we get right away, throw it in there, count it as an influenza, And we knew there were, some of them were probably, they do not have influenza. Some might have had a relative with influenza. We were not trying to go for the perfect. We're just saying, can we for free, it took a guy 2 hours to write the script, right? Can we for free just see what's going on, real-time public health surveillance? The answer is yeah. Once you build an infrastructure like this, you can see what's going on. Again, from a research methodology place, I could argue that it's not perfect, but I could also make the claim it's far better than anything else. And guys like Mike Wagner and the kind of money that people in Pittsburgh and stuff spent to do the same thing was a lot higher. So, we'll talk about the technology for just a minute so you get it again. It's real simple. We just had, for those of you know, we just had a flat file structure. That's how Vanderbilt's whole data structure works. It's just a big flat file. It's indexed by a patient identifier. That's it. And it's just a big giant heap of stuff. And all we did was create logical partitions for each institution. That way, each institution could say, I'm Columbia Press. Well, they would have a separate logical partition than NYU would. And so then, technically, until a patient was seen, they could, with approval, back out of the whole deal and erase all their data. It was like off-site storage. The minute, of course, a patient was seen, all those data were wrapped into the audit logs and you couldn't revoke it, right? So we had a database, it could not repudiate findings, it was completely auditable, but in a sense, everybody felt a sense of ownership and protection. Of course, privacy and security is tantamount. This is actually kind of a basic version. We popped up this window, that window on the right with that plot. That is basically sanitized data of a real patient. And the green things there, that's the normal ranges because it came from about 5 different institutions. Down below, you'll see something, if you're clinical, you'll say that's basically a complete blood count, rows and columns. But the thing, again, that's not one institution. That's a bunch of different institutions with different instruments, with different data structures, with everything else coming in, and it made it look like one institution. And that's pretty powerful if you're a clinician. It's still a nightmare when you try and do the analysis, but at least for a clinician it was good. Because now we have communities that understand they can trust each other and cheaply put this data in one place. Nobody ever used those pop-up graphs for anything else. Forget it. They just don't use it. So, impact. We basically are going to be publishing a study about the financial impact. It's been difficult to do. I'll just go through this real fast. But we basically were able to take about 20,000 people for whom the exchange was used over a 2-year period, everybody. We took 20,000 matched for age, sex, gender, provider, place, payer mix, everything we could think of, and the other arm. Then we found some patients in both arms and some exclusions for various reasons. Got down to about 16,000 different people. And we basically then looked at, compared the two. And so we had a nice case control design and things like that, and we basically had 2 arms because what happened was one big hospital chain was doing it using print and everybody else was using the web. But the other thing was this hospital was a very suburban thing. I don't expect you to see much, but if you look on the right-hand side, those are more the inner city. Guess what? More Medicaid, more self-pay. The one on the left hand was a big chain out in the other county that basically had a lot better payer mix. And it turns out when we looked at every statistics, CT scan utilization, admissions, everything, the one on the left where you got paid more, you did more, what a surprise. So we analyzed them as 2 separate arms. But what we found was actually pretty striking. There was this dumb thing put there, you didn't have to use it, good if you wanted to, no incentives, and we found that we decreased hospital admissions to the tune of about $1.5 million a year. A couple admissions a day fewer for the metropolitan region. That's no great shakes. But we didn't really expect it to do anything because the reason you build these things isn't to decrease emergency department tests, really. I mean, that's one use, and you start there because that's one place where hospital executives can all agree they have something in common. Okay, but the reason we as clinicians want to do it is because we want to take better longitudinal care by hooking up with primary care clinicians and things like that, and we want to understand clinical research, public health across the life of a patient. Okay, so the fact that we could actually show savings in money, and again, that's societal savings. What that means, of course, if you pay me to do something, like suppose I'm a shoe salesman, and I demonstrate that if I tell my staff to sell fewer shoes, I can show a 10% reduction in shoes, am I going to get a raise? No. Because my job is to sell shoes. And there have been instances, Portland, Oregon, for example, where they projected what the financial savings would be and realized that that financial savings would come out of their high. So they didn't do it. Now, of course, with capitated care and all that other stuff, if we don't start thinking like a system spread across New York City entirely, we will suffer because we will start having to pay because nobody's going to pay for a test twice. Remember what I said about the health plan. They see that, and they'll say, you could have gone into some stupid claims browser or something, you could have checked out a CT scan, tracked it down, you didn't, we're not going to pay you. That's the future we're going to face. This stuff is going to be essential to our survival. And then we did find some reductions in labs, but it's only about 2 or 3%. It wasn't very much at all. The real driver, as best we could tell, was by savings. I don't know how well this will hold up. It's about as rigorous as we could do. Because of multiple admissions, we had to use logistic regression analysis with generalized estimating equations. We've gone through this thing 1,000 things. As you know, the real world and doing analysis is a very messy place. So, trust. Tell you about what we're doing now, which is kind of fun. The biggest problem that we have as researchers is how do we get people who are consenting for procedures now to agree to allow our information to be used for research, right? It's a very difficult thing to do. And there are such things as information altruists, you know, people who want to consent now. I believe there's something called an information living will, where you can say after I'm gone that you can have my data. But again, as a husband of a breast cancer patient with 2 daughters, the daughters could say, well, do I really want that available? You know, privacy people have all kinds of issues. But that said, I think there's a potential for us to get more consent over this over time. But one of the other problems, and New York State knows this very well, is every state's got different consent policies, privacy policies, minors, emancipated minors. So what we're actually doing back at Vanderbilt, again, I don't know why I tortured you with this slide, is to basically tell you that we are creating a system where if on the right-hand side, HCO, this was written by the engineers, so they love acronyms, healthcare organization, that's your EPIC, okay? The box in the middle is like a black box that stands between NYU and the outside world, and somebody says, give me some stuff. And that thing, like an expert system, kind of says, who are you? Says who? What do you need it for? Does all those kind of things. What state are you from? What state am I in? And what we are doing is we're taking all these policies from institutions and states, and we're actually doing high-level representational languages and basically creating prologue, logical statements. So you can look across different policies and look for contradictions and like. And because of that, then, you can start enforcing policies for certain use. Now, another thing that we're doing is anonymization. I'm not going to talk about that. That's Brad Malin's show. But anonymizing, mathematically anonymizing medical records, not just de-identification, has got to be a key clinical research strategy going forward. There's just no doubt about that in my mind. And then the final thing is there's a report out there, if you're in informatics, called PCAST. And PCAST basically says, let's stick a little, like we do at Vanderbilt, say I'm a CBC. It says, let's put all kinds of things on that thing. Let's put every little piece of data in context we can with every other piece of data. So every little piece of data, when you think about it, it's got a million different properties associated with it. For example, each piece of data would say, here's where I came from. Here's kind of the context in which I was gathered. Here are the consumer's privacy preferences, with each lab, with each everything. So there's this whole PCAST report is creating a tremendous controversy between people who believe in logical reductionism, that we can just do all this stuff and create this enormous complexity. And people, I'm a little bit on the other end, say, you either trust me or you don't. You got to make it simple. Because I'm quite sure that when we add all these extra data elements, I will be able to prove that they in themselves are contradictory. Example, in Memphis, Tennessee, we had a very simple deal. We just said, you can opt out. You cannot join this exchange if you don't want to. 2% of people in the inner city, 1% in the suburbs said, I don't want to be part of that. The irony being that they probably thought, and New York State is obsessed with this, they probably thought that by opting out of the exchange, that their information was held private, where in fact, their information was sent to plans and sold downriver, however it is, everywhere else. The only thing they opted out of was the one system that if they got sick could actually help them. There's irony to this. So that's why I'm a bit comforted by the FCC and everybody else getting very involved in privacy laws, but I am deeply afeared that the clinical research community has got to figure this out on its own as well, because we could create, in the real-time collection of data, a set of blockades that will prevent us from ever doing clinical research across these populations. If you think about it, if you say the rule is explicit consent for certain purposes, and research isn't there, and you don't know how to play that, there's no way you're going to get that data to do that outside of your own institution. So with that said, I think that the analogues to biomedical research are fairly straightforward. One, if you need to go outside of your boundaries of your own institution, you've got to find a way to collaborate data. Two, the costs of collaboration for research are quite high. Three, the marginal cost of collaborating for research, if you're already collaborating for clinical hypothesis, may be lower. And four, the ability to do real time and take ideas and bring them into practice and execution may be advanced in certain populations. I'm just not quite sure how. So, again, my closing comments, again, is when I think about healthcare technology, your EPIC system, the first thing I think with due deference to the research agenda is make sure the thing pays the bills right. Make sure that when a nurse enters something or a clinician enters, the charge is captured and the bills come out, because no money, no mission. There's no doubt about that. The next thing after that, of course, there's a million things to do to make workflow important in the clinic, and that's important. But the third thing is, how can we be responsible stewards for the data and not just improve our own operational performance? There's so many formalisms that the informatics group knows here that would be extremely applicable, the bottlenecks and processes that mean something to financiers and accountants. There's equally important, I think, an opportunity to kind of study how we can, on the near term and long term, create a research collaboration. And so we need to accelerate the bench to the bedside. We are going to need to find more novel and better ways of collecting clinical data. Patients like me, this self-reporting websites, they're completely disruptive autonomous view. But I think academic medical centers have to pay attention to this stuff, not because, even if you don't care about patient throughput and all the economic stuff, but because if we create a system where consent becomes very explicit and very micro level, and the long-term research interests that might be in the public's interest are not there because of the age-old problem of the public not being aware of the value of biomedical research, we have a lot of problems. So I think it's going to put a lot of challenge on us as clinical investigators. But I understand fully with some of you in this room, I'm bringing coals to Newcastle and I'm in way over my head compared to your own expertise. So with that, I'll leave you. I'm humbled to be here. It's a joy to see it. I'm greatly pleased that my colleague and some of his lab are here and the collaborative spirit here. And I sure hope that I can do more to be of assistance to you. That's all I've got to say. Yes. I don't feel hurt if you leave, you know, you're hungry. Yes?
I had two questions.
Yeah.
The first question was, can you tell me a little bit about what infrastructure, what workflows you go through to guarantee the quality of the data that goes into the exchange? And then the second question was, so if something were to happen, like liability-wise,
Right.
you know, if an ED physician makes some sort of call based on a CT scan at some other institution, you know, they decide not to do a CT there. So who takes responsibility if there's something down the road where, you know, a patient feels like they should have gotten a CT because they didn't catch it, and then they get sued, then who's responsible for that?
Okay, so the two questions, the first one had to do with data quality when you're working across institutions. The second is if you're relying on each other's data, who gets sued, and what's the responsibility. And the answer to the first one is that there's a couple key parts of it. The first is you've got to be very meticulous in real time and double check, which means that if you're exchanging data among each other, that you're held accountable for that. So we basically had a little panel where the people were expected from the institution to publish, but because they're all at risk, they're all mutually responsible, then it was very important. They relied on each other, so it actually became more powerful. Imagine, if you will, for a minute, like, remember Federal Express, you track your own package. It's statistically insignificant to everybody else. FedEx loses your package, whatever, it's one of a zillion, right? But to you, it's 100% of your package, okay? So all of a sudden, imagine if 3 or 4 of you have a package in common and you start looking at that, or you look at each other's package. Let's say each of you have 4 different pieces to solve a puzzle. You want to make sure they all get there. You create that atmosphere, right, and that collaboration sort of happens in quality. But like everything else in the world, when you start making things explicit and measuring them, you may find that things look worse than they are because you're just measuring for the first time. We've had no problems with that. I mean, and because the use is so sparse in the emergency department setting, that has not come up. Now the liability responsibility is actually just a variant of what happens across collaborative complex cases now as well. And the bottom line is I don't worry about that. I tell people not to worry about that much. You have good audit logs, it's going to work itself out. The probability is low, and usually the community standards say the more information you have, the better off you are. I mean, that's been the age-old issue. Liability and economics are always used by people and privacy when they don't want to collaborate. And the liability issues, I'm saying, really aren't anything. If anything, this is going to happen.
So, do you believe that a network of walk-in clinics at the emergency departments linked by a RIO provides better quality care than our current Robert's Welding law?
Oh, sure. I believe that. I can't prove that, but I sure do. I certainly tell you, if you talk to people anecdotally, when you can get a discharge summary, you get the stuff. How many people get the FQHCs and they came from the hospital, you have no idea what happened. You don't even know who their doctor is. Absolutely, we can show that. But we have not begun to look at collaboration and quality of care. I'm hoping that as New York picks up on that, Ray Newkashal's group, who's doing a lot for the state up at Cornell Wild, can do that. That's a belief. I mean, it seems pretty obvious to me, flying in the dark. I think just a medication history ought to be able to improve things, for example. A lot of simple things. Yeah, that's a belief. And I think 10 years from now, nobody will ever believe that we didn't know what was going on with the patients. You know, they won't believe it right that way. Yes, sir.
What did you use as your patient identifier?
We basically created data structures called cliques. We just basically graphed them together on Boolean variables with a bunch of the usual phoneme stuff, the matching sound X codes and things like that. We built a test set of 5,000 names as well and ran ROC curves essentially, sensitivity, specificity, predictive value, all that stuff. And found the match very, very good actually, better than the probabilistic match. And then we just gated it down a little bit so towards the avoiding false positives, we moved it down a bit. So we may have missed a few records, but we did it. And we're fairly convinced that Simple categorical matching algorithms work as well as probabilistic ones do.
Matching on what?
Okay, let me think. Again, some with sound X. First name, last name, social security number, huge. Date of birth, gender, address, that's about it. Same as everything else. And you know, we saw the same things in terms of changing address, and we went through meticulously and found a few cases where we felt it might be two people, both with chronic HIV, using the same ID, because it looked like there were two, but they looked like one at the same time, just like we've seen, you know, New York City's done a lot of that stuff, of course, and looked at that. So I think that the concern over matching is misguided. And we never had anybody complain, but the ultimate issue is to create a system that's responsive, so you see a mismatch, you could just say, hey, separate these two, and have somebody go back and do it. Our system, there was never enough demand, and again, back in 2004, just getting people to trust each other, we couldn't do it. Now with high tech and all this other stuff coming in, you know, the standards are much better, we have a greater chance of doing that. But of course, the other thing, of course, is the predictive value is a function of the frequency of the name. And so it differs from institution to institution, and I personally, that's why I don't believe in a big master person locator in the sky kind of model. I think they ought to be more regional and hierarchical, if anything, or just overlapping. But yeah, again, the things that we thought would be hard problems, I think we fairly conclusively proved to ourselves that we're not, but like so much that we've been done at Vanderbilt, we did it, we proved it to ourselves, but we've not published it. Apologies for that. Indiana's got the best stuff on that. Any other questions? Okay, back, please.
I'm interested in the end user needs for data. So was there like a set template that the ER physicians like with patient history, there were certain number of fields that report to be created, or do they have an ability to customize reports? And if not, who is in charge of providing these reports to providers?
Well, this is what they got. I mean, it was just here. This is all they got. That. I mean, the bottom thing was usually not there. Like I clicked on a report, the report come up the bottom. That's what they got, and that's it. We didn't. Again, we were fairly low funded. There's a woman named Kim Inertle, who folks at Vanderbilt know, who did her PhD thesis on a lot of the preferences and stuff. But we didn't get into usability design at all. We created the simplest, dumbest application we could, with a lot of review, but we basically just said, here are the data. I think, again, I don't want to come across like a nihilist, but I think usability sometimes comes at the expense of performance, in the sense that we get so hung up on small things that we don't execute on the good things right. So I think now is the time to start thinking about those things. I mean, certainly with your Epic install, for example, this is a critical time where that becomes important, day in, day out, small seconds add up. But in this application, in emergency care, we just didn't do anything on it. The governor of Tennessee, a very successful man, had three pieces of advice. Build version 1.0 first, not version 6.0. And everybody that's tried to over-engineer and build one of these things, doing it all first, has failed. Build version 1.0 first. Do one or two things really well. So we just wanted to prove that the ED doc could use it and like it with a simple, dumb thing we had. And three, focus on the average user, not on the high-end user. So I hope, I'm sorry, I'm not trying to be nihilistic, because I think usability is critical in the day-to-day production process we have. But in this application, we just decided not to make that factor. Interesting to hypothesize to do it, and now's the time, I think, to go after that. Does that make sense? You want to?
Yes, and do you have next steps in terms of developing this further to maybe look at clinical data at the unit level for a number of quality indicators, or link data among hospital departments in a single institution?
Yeah,
what are the next steps for this health information?
Yeah, the question was, what are the next steps to do this? And in Memphis, that's up to them. We're doing the same thing in Nashville, just starting, but clearly now we're absolutely going. In fact, my claim is the major reason to do these things, ironically, they're not meant to be interoperability vehicles for meaningful use. You can use the internet for that. You don't need a Rio to connect to the rest of the world with a modern electronic health record. Rather, they are like the old-fashioned CHINs, Community Health Information Networks. The reason you would want to do one here would be measure collectively readmission rates, quality rates, exactly that kind of work. The real, and that's going to be a strength of this institution, I think, better than any place in the city. One can make the argument, I think Cornel Weil's got a bunch of people that are better with clinical surveys and things, you know, Ray New and the crowd from Harvard. But in terms of analytic data and looking what's really important and figuring this out, that could be a real strength here. Obviously, depending on the reports, anonymization is going to be very important as well. But that could be a real strength. It builds on what you already do well. Because that's the reason you do it. So you can go back, so I could go back to your CEO and say, you're going to decrease your readmissions by more money than what this little thing costs to do. That's how you fuel the research, is by asking the right questions. And the scientific stuff you need to do in informatics is exactly what you need to solve the business problems if you pick them up. There's another question back there? Oh, you're right here.
Yeah.
Yes.
You talked about some of the benefits of coordination of care to healthcare providers, and of course the benefits to patients and to society are obvious. Do you see that the potential for healthcare insurers to take more of an active role in this, being that it's in their best financial interest to ensure that patients don't receive services?
Thank you. That's exactly the point I'm trying to make subtly, is that they are going to do it. Because the more we fight among each other, the more they will use the revenue stream where they get it first and do exactly that. And they will use electronic health record to coordinate the care, because they'll say, you guys aren't collaborating with each other, we've got to do it for you. Absolutely. And you won't know what happens, not particularly transparent organizations, why. You will have trouble refuting it. That's why I'm saying the only way to keep parity in the dialogue is to have the practitioners invest some money to do this. And because if you let's say, I'm going to let the health insurer do it all. Well then, how are you going to get data to do your research? Even if the patient consents. Good luck on that. Again, I've worked with those guys. So they're going to have to. Because you see, as much as I love my friends in Washington, they are talking about accountable care organizations and patient-centered medical home. They sound like mantras to me. We all say them enough to think that we know what they are. The analytical power, the challenges with these things, the financial risk to the institution is beyond the pale. So many people in academic medicine talking about these are nothing more than talking heads, or like consultants, creating a demand for their services, and actually doing that analytics is going to be very hard. And yes, I'm saying that of necessity, having lived in that world, that they will and they have to, because we want our healthcare costs lower, and our only chance to respond is to work together across organization areas. That is the strongest point I usually try to get through. Yes. Now you can partner with them. I'm not saying they're good and bad guys, but you have to be upfront about that. You got to think this stuff through, and they're going to raise the privacy flags and everything else because it's just a pain in the butt to them. They certainly, when I used to sell the healthcare plans, I remember e-prescribing stuff in the early 2000s. CEO would say, well, health plan CEO, this helps my members. Yeah. Safer care. Well, we think so. So it helps the practitioner. Yeah. Well, so it helps them take care of all of the patients? Yeah. So it helps my competitors' members too? Yeah. Well, why would I want to help my competitors? Let's move on to the next thing. And they would come to me, and some of them smaller ones, and say, can you give me software to help me identify the sick people so I can get them on my plan before they get sick? And long-term thinking, if you're a third-party administrator, is about 3 years, because people come in and out of plans so much. Our benefits in marriage, we keep looking for the lower prices. Well, there's no critical mass. The only place there's a critical mass is in the federal government, and there's some wonderful stuff going on with open health data, Gov now, and in the large employers with the retiree population. That's the only groups that had a fiduciary interest or financial interest in the long term, including us as consumers. We don't think about long term. We discount future life years like massively, like tomorrow. You know, so yeah, we're fighting a lot of things here. Yes.
So what's your opinion on a single payer system and the potential for that to the development of these health professions?
If you look at single payer systems in Europe, it hasn't solved as much as you think in that regard, and in some of the Scandinavian countries, privacy concerns have shut these things down for secondary data use. There's a level, I know a bit about the NHS, it's been very difficult because it's so massive and monolithic. I think there's no doubt in my mind that a single payer system has a lower overhead, Medicare, than the commercial plans. I reject absolutely the notion that I have choice in my health care through the private market, because my wife, again, has breast cancer, and if I was unemployed, what kind of choice do I have? Even I have the money, I can't. There's a wonderful article by Donna Dubinsky in the New York Times about 2 months ago. You know, she's rich, she built Palm, she was at Apple when it started, right? She couldn't get health care insurance because she had zits or something, I forget what. So there's an argument to that, okay? But I've also seen, and I feel very strongly about this, that the desire to try to put everything into regs like meaningful use stage 2 and stage 3, where you get hundreds of pages of regulation that basically will subject even the most sincere institutions to the threat of fraud, is a problem too. So if I could have my ideal nirvana First dollar coverage by me, transparent prices, in foreign markets evolving over time, catastrophic coverage for reinsurance, means testing for the indigent. I could weave together something from all worlds, but that's me. But don't think that it's not about the payer per se. It's about the incentives, and it's about the regulatory environment. Now, I could have showed you a slide Newt Gingrich had about the 5 million gazillion boxes that Obamacare has, how terrible it is. But what he fails to talk about is we took the private sector market and had one of those for every P&T committee, one for every this and that bureaucracy. We filled the entire Javits Convention Center with those things, okay? He's just got one wall of it because the system is so complex now, nobody knows what's going on. So I just don't think, the payment argument, pro or con, is important as coordinating the data and understanding what patient consent means.
I wanted to ask about the sharing of financial data. Has there been any discussion or implementation of sharing cost data, charges, and reimbursement in the hopes of optimizing the finances of the participating institutions, both internally and against the insurers?
That's tricky. You can't do that because that could be price fixing. You have to avoid a direct financial exchange of data. That's collusion. That's why IPAs like the one up in Long Island that's done so well, is Taconic IPA that's done a lot of exchanges. They basically keep that through a trusted third party. You cannot use those data. When we formed RX Hub, which was a prescription data exchange by the e-prescribing, there were 3 PBMs, and each of us had 4 people from our companies, and we had at least each of us 2 antitrust lawyers. It gets very, very tricky to share financial data, which is, again, the problem with asymmetry. You can keep your own costs, and the plans keep their notion of the cost, but you can share the clinical data, and you can look at publicly available costs and connect it yourself. But you have to be very careful what you put in a data warehouse about finances because of the chance of antitrust.
Yeah, and you're obviously right. The nature of the question was more towards optimization. So,
Yes.
for example, if you know that a particular hospital is treating a particular type of disease or
Right.
population strata in a way that you can compare with your own and you can see what's much more cost efficient with the same quality of care. That's very important knowledge for optimizing care.
Right.
It's not price fixing in any way. It seems to me that unless such data is shared, and it also with regard to the single payer question,
Right.
there is an advantage to having a unified system, or at least a unified treatment of financial information along with medical information.
Absolutely agree, and I'm just saying that what you've got to do is use publicly available data as a proxy. So you don't know what institution A versus institution B's cost or pricing are. You just say, like we did in Memphis, we got to the Tennessee Hospital Association and said the hospital admission median price was $5,000. So you find data, because what you're looking for is findings that are insensitive to small variations in institution pricing. You're looking for the big stuff. Remicade plus methotrexate versus methotrexate alone. The cost-effective studies, you must have financial data for that. My point is you cannot make it institutional-specific financial data from all these institutions together, or you could be, because there will be people who will be threatened by what you're doing because they want to keep control of the data, and they will come after you. But yeah, so I think it's a responsibility when we talk about what informatics is. Part of the deal with medical informatics is to make the case of long-term and short-term financial benefit and cost. I mean, there's no reason we can't look at the research enterprise. And I think tell a pretty compelling story without playing funny financial games. Yeah, so you just got to be very careful that you don't pull it from multiple people. Been there, don't do that. Other comments? Thank you for paying attention. I didn't know what you were expecting or anything else, but I hope I made good use of an hour of your time.